Hey everyone, thanks for tuning in. I'm excited about presenting this topic as a follow-up to last month's topic, which was tissue repair and biokinesiology of the repair process for healing tissue. A lot of what we talked about last month will go into the foundation of how we approach orthobiologics and the therapy post-injection, whether it's PRP, bone marrow, or stem cell injections. So let me see if I can get this to advance. I have an outline. We'll talk a little bit today about indications and utilizations, which patients are appropriate, which tissues respond best. Over the years, we've been working with patients that have had PRP since 2009, let's say. And so we have a pretty big database, and early on clinically, you just kind of piece together which of those patients seem to respond best, which ones don't, correlate that with some of the science. So we'll talk about, you got it?
I'm messing you up, sorry, man.
Sorry, hit mute. Sorry, pardon Cody, he's jumping on.
I muted him, don't worry.
About the basic science behind PRP and how it works. Talk a little bit about the healing cascade, revisit what we talked about last month, and how that fits into a 4-stage healing process post-injection, and revisit a little bit about loading, and like we talked about, especially following surgical procedures or post-PRP biologic injections, how we load tissue is really one of the bigger components of a patient really getting the functional outcome that we want to see following the injection. It's really not the injection and go on and do your thing. It's get the injection and let's follow a logical sequence of phases based on tissue repair. So talk a little bit about a clinical rationale. I'll give you guys a couple case examples, talk a little bit about the literature and what's out there, and touch briefly on maybe the future and the direction that we've seen and that might be happening for biologics and how that fits in with soft tissue, mainly soft tissue injuries and rehabilitation from those injuries. And then if there's time, maybe we can, bounce ideas. How can our clinicians, establish ourselves as specialists with biologics rehab and creating what we call a niche market. We've been fortunate in Thousand Oaks to be able to work with a few different docs that early on were really, I would say, pioneers in driving the science behind biologics. And so we started using trial and error. Like we all practice physical therapy, physicians practice medicine. So we practice, for several years, how do we get these patients better and what makes sense, and developed kind of a niche market. And now we get specific referrals from docs because of our rehab protocols, which we have. Starla has a few that we've developed, and we can share those with you guys at a later date, or they'll be online. Traditional injury management. Patient gets hurt, goes to see a doc, comes to us, or comes to us directly. We attempt what we call quote unquote conservative therapy. If that fails, the old school thought was, okay, let's repair this, or newer school thought, let's look at injections, whether they're corticosteroids, whether they are, viscosity based injections, et cetera. As we all know, a lot of rotator cuff repairs and certain surgical procedures have a high recurrence rate of re-injury. So that, in conjunction with most patients, do not want to undergo any surgical procedures, be out work, be out playing, and they're opting for something else. And lo and behold, 2010, 2012, the rise of PRP came up into existence. I think we all read and heard about different athletes that were going over to Germany and getting some injections. And then you see that starting to happen here in the States with Heinz Ward or a couple of the Yankees, and you read how fast they're coming back. And at that time, they thought that was, the speed of which you can come back. And as time has gone on, we realized that that's not the speed. There is a process that has to be gone through properly for that tissue to repair. So in comes biologic interventions and hopefully tissue repair and recovery and return to work or return to play. And yes, if that biologic/rehab still isn't getting the patient to where they need to get, then potential surgery. What are some indications that PRP and stem cell can be used for? What can it help? So what we've seen the best results, and I'm sure Robert and Kyle and our friends up at SAC and other of you guys that see a lot of biologics, we see some really good results with, the subacute, the chronic tendinosis, the non-inflammatory tendinosis, rotator cuff, extensor radialis brevis, chronic Achilles tendinosis, plantar fasciosis. And the reason I use osis instead of the itis is they are truly, I think, the chronic ones that seem to respond best. With respects to tendon tears, they quantified this. I think the docs and the research out there think that, under 50%, particularly closer to 25% partial tears are candidates for potential PRP interventions. Partial thickness, ligament tears, some of the research I'll show you guys later, under 50% with UCL tears has responded favorably to PRP and post-injection rehab. We've seen a lot of chronic plantar fasciosis where, and a lot of the train of thought with treating plantar fasciitis, corticosteroid injections and ice massage, ice cubes and anti-inflammatories, so a lot of these patients, as you guys have seen, they come back and it hasn't really done the trick, and they've biopsied, tissues out of plantar fascia and looking at blood samples, and there hasn't been a lot of inflammatory markers in those chronic cases. So plantar fasciosis seems to, from what we've seen, really respond well. Another indication that's a little bit newer, I was talking to Kyle a few weeks ago about what they see up there and what we're starting to see down here in the last several years. Subchondral bone, whether it be a contusion or some kind of cartilage, chondral lesion, or early OA. We're starting to see, bone marrow and or stem cell interventions with OA and cartilage lesions, helping with the healing capacity of tissues that we once thought were not going to heal. Basically, chronicity, patients with chronic tendinosis, chronic ligament deficits, haven't had any relief with cortisone, corticosteroids, ice, or anti-inflammatories, for sure fit into the mold of what we've seen really respond well. The one tissue that we have not seen, glenohumeral and hip labrum, for whatever reason, and there's a bunch of reasons, we haven't seen very good results with it. Most of the docs we work with aren't injecting the hip labrum or the glenohumeral labrum. So we actually have one coming in next week that's getting injected down in LA for hip labrum, and I think the doc told him, let's try it because he wants to avoid surgery at all costs. Unfortunately, we just haven't seen as great of results. Contraindications. So who are not candidates? Well, patients that have cancer or history of metastatic disease, cancer that's spread and or potentially being transported in the blood. We're not looking to add more cell proliferation in those cases. Thrombocytopenia, patients with low blood platelets can reduce the effectiveness of the treatment. When they're pulling out and doing blood draws and then spinning it, they're looking for 20 million, a high concentration. So low blood platelets may not be effective. Septicemia, blood infection, using patients' infected blood may spread or create more harmful bacteria throughout the body. Antiplatelet therapy or drugs blocking the numbers of platelets, patients undergoing that also might be contraindicated or not candidates. Real quickly, rehab considerations for patients that might be indicated, and we always leave, like we talked about with our younger therapists, we leave a lot of the decision making to the doctors. We obviously have a lot of influence as therapists, but we do our best to educate the patient within our means about what to expect, what the goals are with biologics. Right off the bat, I know, and we'll have a slide about this, what to avoid immediately following and immediately after. Explain the fact that it's a newer intervention relatively in the last 5 or 10 years. Understand the expectations that, hey, just like surgery, it's not guaranteed, but what will improve your functional outcome will be really adhering to what the doctor wants and what we want you to do in therapy. One of the key considerations, and this is the same thing with most post-ops, whether it's Tommy John or rotator cuff repair, the concept of less being more on the front end is huge, and we'll talk about why. but going slow on the front end and then progressively ramping and going, towards phase 4 and return to play, return to work after a certain time period for tissue remodeling and tissue tensioning is obviously what we need. But early on, less is more. Timing of the athlete or patient is always a big component. Somebody has a trip coming up to Europe, they got to walk up and down Italy in 2.5 months. Is that enough time? We have a kid that's in the minor leagues. He's going back for indie ball on the East Coast. I think December. He wants to be able to throw and be ready. He's looking to have potential PRP for a proximal UCL partial tear. And he's looking to do it in September, which gives us October, November, it gives us 10, 12 weeks or more, which is good. And then, of course, we always talk about patients, should I do this? They ask our opinion. Should we do just physical therapy? Should I go with this injection or should I see another? So, we collaborate with them and again, explain the pros and cons and again, defer to the surgeon or the doctor sometimes with being more specific about some of that. In biologics, what the doctor does is they basically go in and do a blood draw, and they're going to take out X amount of cc's or vials of blood, and they're going to put it in a centrifuge, and they're going to centrifuge it. For those that are familiar with it, I couldn't tell you the exact time it's in the centrifuge. I can't remember. It's about 8 minutes. And then in this middle picture here, basically based on specific gravity, we'll get layers after the sample's been inside the centrifuge. And we're basically looking at the middle layer here being the high concentrated platelets. The bottom translucent layer is the plasma, and up here are going to be red blood cells. So what they typically do will basically draw down this plasma component down to about the 7 cc or the 7 mark here. And then they're going to take and inject the highly concentrated platelet-rich plasma under ultrasound guidance into the specific tissue. We work with some docs that don't use ultrasound. The majority of the docs we use are guiding it with ultrasound, particularly with rotator cuff and more specific tissues where you need that visualization to see it go in and flush into the tissue. I'm going to flip gears. Hopefully I get to the right spot. So with respects to bone marrow, they'll usually take that out of the patient's sacrum. So here's a patient prone.
Kind of emanating pain.
Basically drilling into this patient's sacrum, and they're going to prepare for the needle draw. They numb that area superficially, but
Luga, that doesn't really
the patient, just like she said, the patients we've seen that have had this, there is some discomfort when you're puncturing a drill hole into the sacrum. And then from that point, sorry,
I'm going to feel some pressure.
I'm going to switch gears again. And then once they have that, they'll go in and draw the blood. Again, looking for bone marrow concentrate, stem cell out of the patient's sacrum. We'll see typically bone marrow is being used mainly for those chondral lesions in the knee, in the subtalar joint. And we're done with this one. Just wanted you guys to see a visual. I don't know how many people have seen where they take the samples from, but for bone marrow, it is sacrum. Anywhere else, it's going to be typically just right out of the arm. And tissue healing cascade, just to kind of touch what we talked about last week. The purpose of PRP is basically kind of jump-starting this cascade process in those tissues that aren't healing. We'll describe it to patients like, the battery in your car that's, just not turning over. It just needs a little jump start. Well, those chronic tendinosis, tendon tissues that aren't quite getting there need that stimulus of inflammation spiking. So the cascade, like we talked about, hemostasis, you get the platelets, clot formation. Inflammatory phase kicks in real quickly. It goes for, hour 3 to day 3, something like that, where platelets are activated. The key is that the growth factors are rushing in and mobilizing to help out with cell production, local metabolism, getting that tissue to start healing. We talked about where we typically see most of our patients, they're probably in that proliferative phase or remodeling phase, right? So this is where cells are starting to multiply, and that matrix of newly formed cell production, or think of it as scar adhesion, or type 1, type 2, type whatever collagen is starting to bind down. We'll describe it to patients sometimes, and they ask, why we don't want them doing X amount of things for the first week. Is, simple example, you have a little model airplane and you glue the wing of that model airplane onto the body, and we got to let that glue kind of solidify before we start, jiggling it around. And if it starts moving around and it never settles, well, the rest of the phases, we're at a disadvantage, because the key is probably getting those growth factors and those cells to produce in that inflammatory proliferative phase. And where we really help as therapists is in this proliferative phase and in that remodeling phase, with getting that tissue to line down parallel. And when we talk about parallel fibers to patients, I'll use that example. You have a bunch of that game pickup sticks, right? You have a bunch of uncooked linguine, and you just drop those sticks or linguine onto the table, and they're all they're all meshed up. But what happens if we take our hand and just kind of, like a rolling pin, if we just roll, perpendicular to it, subtly, all those fibers, all those noodles and sticks start lining up parallel. And that's what's happening, hopefully, when we're doing some of our manual stuff and or Therex or NMR or exercise progressions. So the growth factors in that early phase, inflammation, rush in. This is basically the key to how this works, is we get vascular endothelial growth factors, fibroblast factors, endothelial factors, insulin-like growth factors. I'll let you guys read about this later. That kind of rush in and start the healing process. And in that first, quite frankly, 3 weeks, but for sure in those first 1 to 2 weeks, we tell patients, it's normal to feel a little discomfort. Let that inflammation play out. It's kind of the purpose on certain biologic techniques, is almost to spike that inflammatory process. So expect that, and let's let that roll out. If anything, we'll facilitate it a little bit longer to see if we can get better tissue healing. We talked about this last week. I don't know if this slide, last month, I don't know if this slide was in there. This is a slide that we used in one of our chapters. Talks about the phases, and I like this slide because it also shows up top, the cells and what they're doing at what phase. So, like we talked about, early hemostasis into acute inflammation. I think Kyle also is, from what they've seen in Sacramento, we're not opposed to bracing or slinging, a person's shoulder or a person's elbow, and let them take off that sling for everyday stuff. But, I don't want them pushing a shopping cart. I don't want them picking up a backpack, picking up their kids. I rather just, active motion, as long as something's not tightening up. I think being real conservative on the front end in this inflammatory into proliferation phase early. And again, it's up to the doctor, but that's the bulk of where we're seeing the growth factors, the monocytes, macrophages, and the fibroblasts happening within that first 23 days. I think some of the research shows. Again, tissue healing, what does it depend on? This is not rocket science. We need blood flow. Unfortunately, spinal tissue, neural, spinal cord, and certain central nerves, nervous system tissue does not repair itself. You get a peripheral nerve lesion, they heal, but very slowly. So, ligament and cartilage, not great blood supply. Tendon, not great blood supply, particularly insertionally. Bone, an abundance of blood supply, and muscle. So early on, I don't know why the Jacksonville Jaguars are out here, and we saw a bunch of hamstring subacute strains, and the doc injected them, and we got them into therapy. You just start seeing things happen real fast. And, when we see PRP for muscle, typically those go real fast. And yes, quite frankly, it's because of the abundance of tissue repair and blood supply that's there, versus tendon, cartilage, or ligament, where it takes a little longer. We have a couple slides as to why we delay the ligament injections, or we delay the rehab, and it's pushed out a little bit and more conservative coming up shortly. This was on a lunch and learn, and this was, I think, a slide that Starla also presented a couple weeks ago. Again, this is a good review just of, clot formation, growth factors, inflammatory molecules, fibroblast proliferation in that 1 to 2 week mark. And again, collagen deposition and revascularization in the reparative, going in towards, a healthier matrix, or a more, organized and hopefully less cross-linked remodeling tissue that was injected. And obviously, we look, to about 6 weeks to 12 weeks, 6 weeks to 10 weeks for most of our post-biologic injections to get back to work or get back on the field. Bone fractures and certain tissues remodel and take up to years. So that's why you'll see days to years on the remodeling phase. Patients always ask us, how much does this cost? We always defer it to the patient, obviously, to the doctor, obviously, but typically, corticosteroids, cortisone, epidurals, they're covered by insurance. Viscose supplementation, Monovis, Orthovis, Synvis, you guys have been seeing probably over the years. Sometimes that's covered by insurance. Typically it's not. PRP so far, for the most part, as well as stem cell and BMAC, are not covered by insurance, unfortunately. That's a relative cost. Just you guys, if you're not familiar with it, that's typically what patients are paying cash. We had a patient that went to, where'd she go? Bahamas? I can't remember where. Grand Cayman. They have a cocktail down there that's different. I think she paid $5,000 or $6,000 for that, which quite frankly is probably not necessary, but that gives an indication of some fiscal, which is a big component of it. You get people going and paying $500 or $4,000 and now they're coming to you for rehab, and we have to do our best to make sure they're getting the value out of not only what we're doing with them, but the value out of what they just paid to the physician to do this injection. There's a lot of different literature out there that's kind of all over the place. It's probably not standardized. It basically demonstrates significant variability anywhere from how long should someone rest? Should someone just be cleared to go walk out the door and get on a treadmill a day later? Should they reduce weight bearing? What type of exercises and when should they be implemented? Return to play, return to work is not well delineated out there. And, as is whether someone should use NSAIDs pre or post treatment. A lot of articles out there, proposing standardized rehab, but there's not very many that have. So in a nutshell, this creates what we think is a unique opportunity for us if we've, developed a database and we can go out to doctors and say, hey, we have protocols for your patients that you just injected. Let me show them to you. Or, we have some literature that's been published at Spine of Sport. Here, let me share this with you. It creates a good opportunity for us as therapists and athletic trainers and healthcare providers, to target another market, and of course, help a sector of the population that's really starting to utilize non-surgical interventions like biologics. Literature says, not all PRP is created equally, right? So early on, I remember they tried to figure out what diameter needle they should be using, right? So how they harvest and pull the blood out. If they had too narrow of a needle, well, some of those platelets are getting damaged right off the bat before they even centrifuge it, or vice versa, going back in. So, from what we were told, and what one of the docs uses that really is a pioneer, uses a 17 gauge needle to minimize those platelets from getting damaged. And again, if you're putting in platelets that are damaged right off the bat, they may not do what they're supposed to do in spiking some of the growth factors. So immediately the harvest technique was paid attention to. The systems, that they were using to spin and or formulate PRP, leukocyte rich, leukocyte poor, more platelet count, less platelet count, white blood cell concentration, et cetera. How many injections do patients need? We see a multitude of different doctors that do, for the most part, people do 1 to 2 injections. One of the docs with the U.S. national soccer team had a protocol where he would do 5, and had another patient just had, after 2 years of Achilles tendinosis, she actually had 3 PRP injections plus the rehab. I don't know if the rehab's gotten her better, but she's 85% better after almost having, a DASH score of like 30 for 8 months straight. She got to us later, actually. But so the number of injections and the protocols and how many are being performed is still not standardized, as are the injection rehab protocols. So with that, we came up with some, put together our heads, and in 2008 into 2012, got a chapter published based on clinical experience, and we actually put it and got accepted into Jim Magnuson from our Oxnard, our performance PT partners right here. You guys probably don't know, Jim published a book, great book that's being used by a lot of orthos that covers post-op, post-surgical orthopedic protocols. Well, we had a protocol for post-injection in there. And then fast forward 10 years later, we just this year punched through 2 more chapters. They're going to be coming out in physical med rehab clinics in North America. Once they're cleared to view pre-print or pre-online, I can send them out or give them a star list. So for those of you that want to learn more and read more, we have 2 chapters. One's ligament specific. The other one is just generalized tissue, covering all the tissues. And in there are more specific protocols with types of exercises and what specific exercises. And the purpose of today is not to talk about specific exercises. It's more of a global, hey, this is when we would integrate this, or this is when we'd integrate that. So as soon as I can get those out, we'll pass them along to you guys. What do we tell patients, or what does the doctor tell patients to avoid right off the bat? Well, we stop all NSAIDs prior to the procedure. Give them an understanding of the vascularity and what the injection is supposed to do. Post-injection, patients go home with actually a heat pack, typically on that tissue, on that shoulder, on that elbow, on that Achilles. We don't use any iontophoresis or phono. The concept of tissue protection and loading in the first 2 to 4 weeks is key, and we'll explain that to them. Dynamic muscle ultrasound, number 6. We'll talk about that in a second, is commonly used at about 6 weeks, 8 weeks after that remodeling is well underway, to then determine the tissue integrity and or joint stability, and potentially can we progress that patient to throwing, or can we initiate, sport specific, work specific lifts, etc. The goals are pretty, like every post-op or injury impairment that we're treating. It's really to progressively and therapeutically stress tissue with loading to facilitate tissue healing. Early on, less is more. The type of stress, like we talked about in loading last week, we're looking at tension for ligaments, at a certain point, basically 7 weeks that we've learned through research. 7 weeks out, starting putting a valgus load through that UCL, progressing muscle/tendon from submax isometric to max to concentric to eccentric to plyos or ballistic loading. Similar like we do everybody that's non-injection, non-surgical. We're putting in torsion and shear controlled stresses to the joint to stimulate cell production and get that joint to respond. Similarly with annular and cartilage labrum, stresses. I just got off the phone with the doc that has one of the Rick knows him, Dr. Molnar, started doing annular injections into the annulus to help contain the disc material. So at what point do we need to torsion and shear those annular fibers to get them to respond and firm up and basically adaptively be able to withstand the stress? That's an important component. Without ever stressing that tissue, it's got to firm up and become better tensile, increase the tensile capacity. So manual therapy, dose medical exercise therapy. I know the guys down in Ola Grimsby in San Diego do a great job with, exercise prescription, and exercise prescription manual therapy is a huge component post-injection. There's not an absolute progression. It's not like every patient, moves on to this, moves on to that. There's always variability, just like all the patients we have and the post-ops that we see. The specificity of exercises and integrating very specific throwing exercises, integrating very specific, squat, turn, torsion, integrating very specific lifting exercises to enable return to work and return to play simulation is very important. Just like Dr. Verna talks about, higher intensity and loading some of our back patients, to get that tissue to respond and build the endorphin kick and the stability. It's the same concept. We have to keep progressing exercises to the point of what does it take to get that tissue to be able for that patient to do, whether it's throw, lift, sit in a chair, pull a weed, whatever it might be. The ultimate goal is always patient satisfaction. So, I always put that in every goal, for patients. We want our patients satisfied. We want them to come back, refer their friends or family. And I think a lot of times therapists miss the concept of the physician is really also part of that. We want to make sure our physicians are satisfied. The question that we all probably get it every day, every hour, when can I do this? When can I do that? Timeline. So typically, like I said, we're looking at a 8 to 10 week for some tissues. For ligament, it's going to be more like 8 to 12 weeks, depending on the amount and the extent. But anywhere from rest For muscle, belly, like I said, some of the sports guys we've seen respond really well, really fast with muscle belly injections. Tendon takes a little longer, ligament takes the longest. Post-injection, you might move through this a little quickly just for the sake of time, but like we talked about last week, 0 to 7 days inflammatory phase, that's where we're looking for it to spike. We tell the patient, hey, you might be a little sore. It's going to be like an inflamed soreness, like an ache soreness. Someone that comes in, it's like sharp, lancinating, electrical pain. That's kind of bizarre. We're looking for that patient to come back, within the first week. And I'll ask them, hey, did your elbow or did your shoulder get sore? I'm hoping actually that they say yes. It got really, really, really like achy, really inflammatory type soreness, because we saw early on, and we still see it. For whatever reason, those that come back a little sore right after the injection, that inflammation did spike. And for some reason, those that come in, they say, oh yeah, I felt pretty good, normal right after. I'm always a little worried about those patients. I don't tell them that, but it's just something we've seen clinically over the years. Goal, allow that PRP to absorb, allow that model airplane wing glue to really solidify, start that cross-link initiation. We'll get them on an index tool. For throwers, we use the Curlin-Jobe score, which for those of you guys that are working with overhead throwers, pretty good score, functional scale. It correlates, I think, pretty well with the sport dash. Could be a knee scale, could be the SPOTY, whatever the functional index score is. We'll take that again right after injection day 1, and then we'll compare it at 6 weeks and at 12 weeks. Phase 2, hopefully into that first 3 weeks, the cross links are formed. We're getting them doing active motion. We don't want them lifting and loading and putting over amounts of weight through the joint, or lifting any weight that's going to put too much tension through the ligament or the muscle belly or tendon. We do initiate soft tissue mobilizations, but we're doing it lightly and in the line of the tendon. We're not going transverse friction. Again, the last thing we want to do on a post-op cuff repair, the surgical repaired, is pull out a tool or do friction on it, right? So it's the same thing with post-injection. In that tendon line, or milking that muscle belly towards the tendon to improve blood flow is really the goal. Reparative phase, probably the most important phase. This is where our exercise progressions really kick in. And we want to, we do want to see that inflammatory phase, reduce and spike down. The gap hopefully is filled with better collagen production. The collagen synthesis aligns, the tissue starts withstanding tensile forces. They can start doing light activities. They're already, into high repetition exercises. Again, for exercise early on, we're looking at an endurance capacity. So to improve vascularity, we have people doing 25 reps, 3, 4, 5 sets actually. And again, we'll adjust the weight. If someone's doing, X amount of weight for external rotation, and it's no problem, we'll go up on the weight. But I definitely want them hitting 25 or 30 repetitions. Again, more endurance and more vascularity versus quote unquote strengthening. Start simulating things that they got to do, working on proximal mechanics and flexibility in other joints. Avoid ligament stress. For ligaments, avoid all ligament stress for 7 weeks. And some of the data that's come out in the last couple of years, they've seen that it takes about 6 to 7 weeks for UCL in particular for that gap to close in the elbow. For eccentrics and muscle, we look at integrating eccentrics around the first month, sometime between 4 or 6 weeks. Concentrics, starting week 2, week 1. Blood flow restriction, we're for those of you that have it coming up, or sorry, for those of you that have in your clinic, it is coming up. Starla, I can't remember, September, October, there's gonna be a great talk on BFR. So we have it, we definitely integrate it for the purpose of increasing loading to that muscle or that joint without having to put a lot of load through there. So we can really load, quote unquote, joints and muscle tendon without a lot of resistance or without a lot of weight bearing. So it's been shown to increase muscle mass, strength, as well as cross-sectional tendon stiffness at a very low load, which is great for that's the win-win for biologics, is low load, high rep. So early on, we're starting to use that. Oh, wow. Starla, what happened? Sorry. I don't know what happened. There we go. Yeah, BFR. So we know research shows it increases growth hormone secretion. It enhances tissue repair, increases collagen deposition, increases blood lactate, which then helps with cell energy and local metabolism. And there's a kind of an endogenous opioid release in the form of beta endorphins. So I'll let our partner talk about this next month. But all of these three things we're all looking for in tissue repair and post-biologic. So if you guys have BFR, it's a good tool, good adjunct to what we're doing as far as the rehab. We don't have shockwave therapy here. I don't know if a lot of PTs do. It was something a long time ago that we used to see a lot of. You're starting to see it now in the training rooms and with a lot of the professional teams. Look, this is what the research shows it does. It promotes neovascularization, stimulates proliferation of tenocytes, helps with leukocyte infiltration, which I just talked to this doctor about annular tears. He thinks that some of the end plate disc issues that pop up with bacterial or infection are minimized when he uses leukocyte-rich, platelet-rich plasma, and has to do with that leukocyte-rich fighting off any kind of potential bacterial complication in the disc or in the end plate. So shockwave therapy helps with that. It amplifies growth factor and protein synthesis. So all things that we see that we're looking to try and enhance. You'll see that in the literature or being used in some training rooms and physician offices, podiatrist offices, et cetera. Phase 4, we're looking at sport-specific stuff, eccentrics. Diagnostic ultrasound is being used by a couple of the docs, again at the initial phase to diagnose it during the injection, and again at about 7 or 8 weeks to determine how much healing has occurred, if it has. And depending on what tissue it is, we'll get the clearance from him or her. Hey, let's start valgus loading, or let's bump up in the next 3 weeks. We can start telethros or interval type progressions. So in that phase 4 post biologics, we're looking for full functional or sport activity, 10 to 12 weeks. Sometimes it's shorter, sometimes it's later. But I think if you look at some of the research, and if we ask our the guys and crew up in SAC, they might be seeing something similar. I don't know. This is one of the pieces of literature I think is a real good one. This was put out back in actually 2010. It finally got published in 2013. Dr. Elitrash, who's a Rams doc and Dodgers doc, recommended this get put through with Dr. Yoakum and Dr. Podesta, two big giants in the world of baseball medicine. We rehabbed 18, I think, maybe 20 of these 34. It was one of the first papers out there in American Journal of Sports Med that showed the effectiveness in leukocyte-rich LR-PRP. They looked at a 70-week follow-up. Basically 30 out of 34 returned to that same level or higher within 12 to 15 weeks post-injection. 3 of those players were unable to play. One had a labrum issue, and I think that was one of ours. And one of our patients also had MS, multiple sclerosis. So they weren't sure if there was a tissue healing complication or comorbidity with MS. But basically looked at a positive KJOC score. The DASH score improved. They did a baseline musculoskeletal ultrasound. And when they do that, they do basically with and without a weight. I'm not sure, in my opinion, they probably this kid's a thrower, probably put him at 90-90 and get him in his 30-degree slot and simulate that release point. But this is the position they do it in typically, but it's a weighted and an unweighted stress test, and then they'll take a snapshot and measure the distance, how open that joint is. Again, stressed, you're going to see this, and stressed pre PRP, and then 8 weeks post, a little bit narrow. And I can't remember the numbers here, but they were within significant findings statistically. This is an example of a UCL. It doesn't talk about the actual exercises. We have that in the chapter. Again, if you guys want, we can get you that. And there's kind of like a cookie cutter approach to, here's a bunch of exercises for phase 1, for phase 3, for phase 5. And when would you progress to this based on criteria, full range of motion, pain-free with stress tests, normal ultrasound findings, et cetera.
Hello.
Outcome data. KJOC score again showed a pretty significant change and positive result. It correlated very well with the DASH score. Again, dynamic ultrasound, that gap closed down from 3, down to the 3.5, from 7 down to the 3.5, 4 on the 8-week post Second study that was also coming out of KJOC more recently, basically looked at freshmen in high school that were, post injection all the way to Division I players 9 years later. At the recreational level, all of them were able to continue playing. Not all continued playing for over 4 years, but none of them stopped playing baseball due to the ulnar collateral injury. It was probably, burnout, fallout, or onto other sports or onto school. The future of biologics, well, it's an evolving science. Bone marrow and stem cells weren't around, or we weren't seeing them back in 2009, 10, 11, 12, 13, et cetera. So it's evolved from, using PRP, pulling out of the arm, to, bone marrow stem cell, where they'll, take it out of the sacrum, use it for more chondral and joint lesions. There's a concept of resident cells that they're using to extract synovial fluid cells, spinning those down and then injecting that back into a joint to help synovialization and the chondral synovial lining. And like I mentioned, Dr. Molnar is starting to look at using it for intradiscal issues and containing potential nucleus pulposus disc herniations that might further exacerbate. So the application, what they're pulling out and how they're using it, and probably the specificity is probably really the best part about what's happened. In summary, we're good on time, Starla. In summary, the efficacy of biologics therapies is very dependent on, the formulation and the injection, right? If you don't get the blood out the platelets out clean and inject it actually into the tissue, that obviously we're not going to get the same result. As are if the post-treatment is run too fast or too slow, we'll run into complications on that. The cell lines and the grafts need to be allowed adequate time for collagen deposition, cross-linking, and ultimately tissue proliferation, which is really the goal of PRP, is tissue proliferation. The use of biologic cell therapies promise to become a potential powerful therapeutic modality. And I think we're starting to see a lot of docs in this area, whereas many ortho physicians and non-orthopedic physicians kind of poo-pooed it. A lot of them are not doing it because patients are going in. The sports med ortho specialists have been doing it for years, and so I think it's on the rise in not just the ortho world, but the non-orthopedic physician world. And don't let anybody tell you otherwise. Doctors might say, yeah, go do this, go do that. But I am a firm believer that what we do as therapists, just like after rotator cuff repair or ACL reconstruction or what have you, makes a big difference in the outcome. And so we had a lot of trial and error, but I think after probably 250 visits, times 10 to 13 visits per eval on that metric, that's a lot of seeing what works and what doesn't work. So again, we're happy to share some of that more specific data and info with you once we get the okay to do so. So that's all I got. And any questions, or if you guys ever want, we have protocols for proximal hamstring, for supraspinatus, for Achilles, post-Achilles injection, patellar tendon injection, weight-bearing tendons, which take a little longer than normal tendons, that we send Starla, and she can pass on to everybody.
So at this point, you're probably all familiar with iSolved University. If you're not familiar yet, it's what we're using for our compliance training. So you will be familiar by the end of next month. But I just wanted to point this out to you guys. So I did upload the protocols onto iSolved University, so you can find all of them on here. So I have one pulled up for the hamstring tendon. So you can see it's kind of all laid out by week and everything. And then we actually have a downloadable document posted right here in blue. So in order to get to these, if you're on iSolved University, if you just go to library and then articles, you can just use the search feature for rehab protocol, hit enter, and then you'll see the ones that we have uploaded so far on here. And this is a database that we're continuing to build up, so stay tuned. We'll have more stuff in here moving forward. All right, I know it's 1 o'clock, so you guys probably have patience. So thanks for joining. I'll post the recording to our YouTube channel like usual. And then next month's Lunch and Learn is going to be with Sarah Hare, and she's going to be talking about some pelvic floor techniques that the typical orthopedic therapist could use for your patient populations. All right, thanks so much, Eric. This was awesome.
Yeah, thanks, guys.
See ya.
Thank you.